Hi, I'm Jinho. I'm going to talk about brain mechanics related risks in deep brain stimulation with an emphasis on brain shift and DBS electrode misplacement. DBS has treated incurable neurological diseases like Parkinson's disease now for more than 40,000 cases. However, its various side effects make it difficult to become a more popular therapy option for patients with other candidate diseases. That is why it is worthwhile to look at the phenomenon of electrode misplacement in DBS that is considered to be behind unexplainable neuropsychiatric side effects. We will first review some of the basics of DBS. DBS elevates symptoms by electrically stimulating the targeted deep brain structure using an implanted electrode. To insert the electrode into the target, stereotactic surgery is performed, where the electrode insertion path is pre-calculated by 3D coordinates obtained from a pre-operative MRI scan. For decades, DBS electrodes are almost universally made with stainless steel and in a cylindrical shape with 1.27 mm of diameter. They target the neural structures that are also on the order of millimeters in dimensions, and that's why electrode misplacement can be risky. Now to understand the misplacement problem, let's review the concept of buoyancy. Force of gravity exerted on the brain is usually cancelled out by the force of buoyancy created by CSF, and that's how the brain maintains its shape. But when the CFS leaked through the burr during the implant surgery, the force of buoyancy will be decreased, and this instant imbalance between forces causes the brain tissues to shift within skull. In a unilateral insertion of the electrode, the CSF leak induces a lateral shift of the brain because of the support from the contralateral side. In a bilateral insertion with bilateral CSF leak, the whole brain moves down in the direction of gravity. If the electrode has been implanted straight into the pre-planned path, the tip can be deviated from the surgical target up to 5 mm. Even if neurosurgeons somehow successfully implanted at the desired target, the electrode can still be dislocated post-operatively when a large volume of air has been invaded during surgery. It takes weeks for the pneumocephalus to resolve and the cortex to slide back to its original position. The upper half of the electrode wants to move along with the cortex, but because it has been tightly secured in the top by the ball cap, the electrode as a whole forms a curvilinear shape. As a result, the electrode tip is lifted from its original target up to 13.3 mm as shown in the picture. There also exists a positive correlation between the subdural air volume and DBS displacement. In conclusion, the current DBS surgery procedure is prone to cause brain shift that leads to unwanted misplacement of DBS electrodes. As of now, there is a definite limit in understanding how the dislocated electrodes affect the living patients, and the best thing we can do is to simply avoid it. To do so, the following innovations are expected. First, upgrade outdated electrodes. Second, improve surgical techniques. Third, introduce finite element method-based simulation tool that can guide either intraoperative or postoperative brain shift. With these improvements, we hope more diverse patient groups can soon access the clinical benefits of DBS.